Hi everyone, I want to talk about pain treatment, and today it will be about lesson 3. What will be in lesson 3? Okay, let's go. Let's find out. Yeah, it's going to be about nociceptive pain. And like I've said about neuropathic pain, I will not go into all the nitty-gritty as far as nociceptive pain is concerned. I'm going to limit this to pharmacologic approach. How are we going to help anyone with nociceptive pain? But briefly, I'll go over the characteristics of nociceptive pain. Nociceptive pain is coming from damaged tissues. Nociceptive receptors are all over the body, and it can dictate noxious stimuli. They give warning about potential damage to the affected organ or the entire body. From inflammatory processes secondary to infection, arthritis, trauma, burns, or obstruction, then the information will be sent to the central nervous system. Nociceptive pain could be aching, characteritis, throbbing, waxing and waning when it's affecting the hollow viscus. Could be constant, localized, or poorly localized. Predictably, it responds to treatment, and there may be complete resolution once the affected tissue or organ has been treated and it has healed. So you can actually get to the end of the trouble when it comes to nociceptive pain when the affected organ or tissue has been treated and healed. And there's no need of lifelong or many months analgesics with nociceptive pain. That could not be said when it comes to neuropathic pain. There's possibility of mixed nociceptive and neuropathic pain, and that will involve a complex mixture of both. First of all, there will be tissue damage, and that will lead to both neurogenic and tissue inflammation. Migraine and facial pains are typical examples here. And the treatment here will involve non-pharmacological approach, psychotherapy, non-opioid, with opioid, with or without adjuvants like anti-epileptic drugs, tricyclic antidepressant, selective serotonin uptake inhibitors, or calcium channel blockers. You can also use topical agents as well. Okay, before we start loading this individual with lots of medications and be battling with the side effects and feel concerned about what is happening with the hepatic system and renal system, let's try the non-pharmacological approach first. Okay, relaxation techniques, the breathing relaxation, acupuncture, physical therapy, occupational therapy, pet therapy, music therapy, gel packs, ice or heat application, massage, and aerobic exercise. For us to make appropriate selection, I will still go through the World Health Organization pain ladder. At the bottom of it are the people with mind pain, and we don't expect any doctor treating anyone with mind pain to start with functioning ibuprofen or morphine. So we're going to start with non-opioids like acetaminophen, that could be paracetamol, Tylenol, or whatever, depending on where you are on the surface of the earth. And with NSAIDs, non-steroidal anti-inflammatory drugs, you could use aspirin, and you may decide to use adjuvant therapy as well, like antidepressant, gabapentin, anti-epileptic drugs, and so on. But if the pain is mild to moderate, you can choose opioid, not so strong ones like codeine, tramadol, or oxycodone, with or without non-opioids, and with or without adjuvants. But if it's very severe, then you go for strong opioid like morphine, fentanyl, and hydromorphone. You may add non-opioid or adjuvants. Okay, I've taken everything into consideration. Now I've gone through the letter. I have tried the non-pharmacological approach. The history has been done. The diagnosis has been made. Now I have my mind made up to place this man or woman on analgesics. So how do we go about it? Okay, I'm going to treat the specific diagnosis first, because if you don't get to the root, you're not going to get the situation out. And I'm going to select medications based on the diagnosis and possible risk factors. That is, what is the glomerular filtration rate saying here in case I'm suspecting renal failure of any nature? What about liver function tests and liver enzymes in case of hepatic failure? This individual has been diagnosed with peptic ulcer disease before. Is that the case? If that is it, am I going to grab proton pump inhibitors right now? Of course I have to. And I'm not going to go for medications like ibuprofen that will worsen the peptic ulcer disease for me. I would rather pick celecoxib. And if I do, I need to check what is happening with cardiovascular system before. And if that is not the case, why not naproxen? Okay, so there's so many things to take, all right? So if the pain is mild, I'll be comfortable with acetaminophen or non-steroidal anti-inflammatory drugs with or without proton pump inhibitors. Because if you are selecting celecoxib and there's no cardiovascular problem, you don't need proton pump inhibitors. But if you are choosing ibuprofen, even if the individual has never had peptic ulcer disease before, you don't want to give one now. So just picking your omeprazole will help, okay? And of course, with or without tricyclic antidepressants or opioids, and you can use baclofen or tizanidine. If moderate or severe pain, you can start with acetaminophen, combine acetaminophen with opioid, non-steroidal anti-inflammatory drugs with proton pump inhibitors, tricyclic antidepressant or duloxetine that is in both opioid, baclofen, tizanidine if spasmodic. There's a lot to choose from, right? We have to consider risk factors. It's just wanting to know, you've been to school, you have your degree, you passed through pharmacological exams, you passed brilliantly. Now you want to place my grandfather on medication, old age. And you've chosen non-steroidal anti-inflammatory drugs. Yeah, that's bad. What about the possibility of peptic ulcer disease? That should be taken into consideration. Be careful with NSAIDs or corticosteroids in anyone with peptic ulcer disease. If that is the case, choose celecoxib, okay? If there's a hepatic disease, avoid acetaminophen. Avoid NSAIDs, avoid cyclooxygenase 2 inhibitors. You can use tricyclic antidepressant or Simbat. If there is cardiovascular disease, naproxen is fine here. That's a good news, right? You want to use non-steroidal anti-inflammatory drugs and there's cardiovascular problem, you can still go to bed prescribing naproxen without being anxious. Let's use NSAID less, please. Even with the naproxen, I'm not going to use very high dosage of it. Okay? If there is renal failure, please estimate your glomerular filtration rate. That will guide what you're going to do. And of course, the pharmacists are always there. They will lend you the hand. Just grab the form. But get yourself equipped ahead of time. You can go for Adjuvants, pain medications, NMDA receptor antagonists like ketamine, that's true, metformin, phencyclidine, nitrous oxide, medoxantamine. All these could be abused, right? I have to keep an eye on that. Other adjuvants are anticonvulsants, antidepressants, corticosteroids, sedatives, muscle relaxant. I think I'll be more comfortable with anticonvulsant and antidepressant, less comfortable with corticosteroids, and of course sedative is used almost every day, and muscle relaxant, I'm fine with that. But as far as ketamine, dextromethorphan, phencyclidine are concerned, I would not be too ready for that. And you could go for non-opioid analgesics like acetaminophen, aspirin, in combination here. Okay, opioid analgesics like morphine, hydromorphone, oxycodone, codeine, fentanyl, or buprenorphine will be chosen later on when you are not winning with the non-opioids like acetaminophen or non-steroidal anti-inflammatory drugs. You can also use topical agent. This is necessary because I don't want the patient to suffer, right? Because being in pain is a form of suffering, okay? So as much as I'm careful about the possible side effects, I need to take into account the pain that my patient is passing through. So if I don't have choice but to give opioids, I'll go ahead and give it. It's only will be very, very closely watched. Okay? Topical agents could be used: capsaicin, Votrient, Pensate, local anesthesia, general, regional anesthesia could be given. Some use propofol in the past. I don't want to go into that. We know what killed Michael Jackson, right? Combination of some of the above could be used most of the time. But when we are making those combinations, we'll also be careful about the combined side effects as well, or withdrawal symptoms later on. Okay, with that, I've come to the end of this very presentation right now. I'll move to opioid side effects next. Kindly subscribe to my channel so that you can get these presentations immediately they are published. Thank you.